Hello, everybody. Welcome, welcome, welcome. Hello, Alicia and Jennifer.
Hello.
Hello.
How goes it today in your neck of the woods? A little windy where I am.
Yep. My hometown got almost blown away, though, up in Missouri. But I'm in Texas, so we're good.
What was it? A 3 you said on the pre-webinar here we were talking about?
Yeah. My little history of my family, but so it went through two towns, or went through more than two towns. But my cousin owns, I think, all the Sonics in Missouri except for one, and the one in Jefferson City leveled it. So, and I guess, well, I mean, it didn't level. There's still some pieces standing, but I don't think nobody was hurt. I know, but I don't know if people were actually working. I hope they weren't, because I don't know exactly what time it went through. But
well, I'm glad everybody's okay. Put it that way.
Yeah, everybody's good.
Yeah.
Hello, everyone. Hello, Coquette, who's saying hello to us already. Thank you, everybody, for joining us here today. So let's get started with
Whitney.
the May. Oh, sorry. Hello, Jennifer. Sorry. Go ahead.
Whitney's.
Oh no, you're good. You're good. You're good.
She's just mentioning somebody to be on all the webinars. Whitney. Hi, Whitney.
Oh, Whitney, of course. I only saw, I got to make my little screen there bigger. There we go. There's Whitney. So welcome to the CCO Certification Coaching Q&A webinar from May 2019. Along with me, Jennifer Saunders and Alicia Scott of the CCO team. Behind the scenes here today is also Lori, who's helping us out with the Q&A and the chats and our questions that get copied to the end of the webinar for those people who are joining us. So welcome. Right?
Yeah.
Right.
So welcome. If this is your first time, we're going to hear from you in a second, I think, with a survey. But if this is your first time, and in fact, welcome to the CCO community. We really enjoy you being here. And this is a general webinar about all things medical business, certification, medical coding, billing, and practice management related. As always, and you've probably heard me say this a million times now, or at least for a couple of years, we can't hear you. You can type a question in the chat, and we'll attempt to answer during the webinar, but it's not that easy, as you can imagine, with all the people on the webinar. And also stay to the end for a free giveaway that we always do for those of us who are joining.
Yep.
All right.
Oops, wrong thing. Sorry. I hit the wrong screen.
So first survey, and I'm going to start this one, is how many webinars have you attended? So get ready with your finger on the trigger. Yeah, is this your first time? Are you back for more? For just one? Or are you 2 to 5, a repeat offender, 5 to 10, liking it here at CCO, or a frequent flyer at 10 plus? Take a good guess.
I've gone to 99.98. No, yeah, I think I've only missed one or maybe two in 8 years.
I'm a frequent flyer now.
Yeah, totally. So we're going to close that poll because you guys are doing so good, and I'm going to share that sucker. First time, 22%. Awesome. Welcome, everybody. For being here. And back for more, 15. Repeat offenders, 21. Liking it here at CCO, 13. And frequent flyers, 29%. So
yay.
Welcome, frequent flyers. You win tonight.
Yay.
Thank you, guys. So this is our agenda. Alicia, tell us what we're going to be doing here tonight.
Well, we're going to have fun because it just so happens that May is Hepatitis Awareness Month. So there were some topics that were out there regarding hepatitis or the liver. So we picked those. I'm going to talk about the anatomy of hepatitis. We're going to talk about coding liver tests. That was such an exciting topic. Jennifer and I both picked it, and we came up with the same answers. And then pre-op chest x-rays. I'm going to talk about that.
Well, we always get questions about the well visits and well woman visits and annual visits. So we're going to answer another question about one of those for coding and billing those, as well as a couple weeks ago, we did a student a free one of our webinars at night, and a lab question came in, and I finally got the answer for it. So it took some time, but I got it. So we're going to go over that one too. So.
See, we really do take the stuff you ask and do the webinars on.
It wasn't an easy one, I'll tell you.
So this is for a lot of you your first time, at least quarter of you. So basically, we've got some questions that we've already prepared that Alicia and Jennifer have just told you about. So we're going to be going over those during the webinar. We're also going to be selecting some questions that you have in from the chat and putting those in at the end. If they're super long, we're going to encourage you to go to the cco.us website and go to topic request and put them in there so everybody can enjoy the fuller version, if you will. And one CEU will be available in the CCO Club replay area in a few weeks. But there are no live CEUs for some of you who have been here maybe before and haven't been with us for a while. We stopped doing that for some months ago, I think over a year now. And it's basically we don't give out any live CEUs anymore just because it's really heavy for the team to do that. And we always encourage people to basically join our club so we can take better care of them and give them all the resources that they need, put it that way. But again, you can ask a question anytime and use the question box and go to webinar, please. All right. Giveaway, what's going on with the giveaway?
Well, we always like to give something away. You know, we're really giving, we like to give free stuff away. So stay till the end and you can have a choice. You can take a year of the CCO Club Basic, which allows you to access all of those CEUs that we've got in the background. You can take one of our review blitzes, or you can take an hour session with, I don't know, there for a while it was just me, but I don't know, or Jennifer or somebody. Who do you want to talk to for an hour? Again, we'll tell you more about that at the end. But stay.
Yep.
And this is more about the CEUs again. So if you want CEUs off this webinar, we'll get the questions, the quiz created, and you'll be able to get a CEU for it once it's put up in the listing.
And I'll put up a handout here for the slides in the webinar here in a few minutes when we get into our first question. So what is your status? What does that mean, you might ask? Well, let's look at what the options are. Are you looking at a medical coding as a career? Are you certified and looking for a job? Are you employed? Or are you improving your current job situation and trying to earn a new credential? Which one of those best applies to you?
Yeah.
Would love to know. And we got 65%, 70. Good. Thanks, guys, for being on the trigger here tonight. Awesome. Here we go. We're going to close the poll here in a second. And here's the result. 20% say they're looking at a medical coding as a career. 18% say certified and looking for a job. 23% are employed. Congratulations. And 39% are improving their current job situation, trying to earn a new credential, or not trying,
Yay.
but doing a new credential.
That's good. That's good news.
Nice. Welcome.
There's so much out there. So yeah, very good.
We'd like to hear that. And you know what? We can tell you that if you come to CCO and you are one of our CCO graduates, we'll announce it on the webinar. And there happens to be a lot of people tonight, right?
Mm-hmm.
And if you
Yep.
used anything from CCO, then, you know, we want to give you a shout out. And so this is your first time coming to one of these webinars, we like to tell the person's name, and then we have it listed over here, the things that they stated that helped them. And we try to do this every month. So these are recent. Now, do you want to, we didn't talk about that, Jennifer. Do you want to go first, or do you want me to go first?
Sure, I'll go first.
Okay.
So our first one are CPC, so the coder examination. We have Lori Goebel, Jeannie Hudson, Noah Beller, who does also a lot of our questions and webinars,
He's
and
intern now.
Sharon. Oh yeah, Sharon Doughty. So yeah.
Okay. Next, let's see. Still CPC. We have Katie Feltz and Rebecca Muser.
And wow, all the CRCs, that's wonderful. Elsa Brown, Bridget Tomlinson, Deb Gosh, Jenna Cox, and Laura Stevens.
That's excellent. I always love to see the CRCs come in. Oh, looks like we got CRC, CPMA, and COC. Tiffany Wayman, Rachel Babb, and Melinda Paulette Rivera. Yay. I think, oh, one more.
We have Rachel Berry, who did the MTA.
Yeah, medical terminology and anatomy. And that, just a shout out about that. If it is in fact something that we have CEUs for that, and if you are interested in getting some CEUs, it's always good to have a refresher in that. So that might be something you'd be interested in. Well, it's not just us talking about our products and how we, love the product.
And this is where we lost her, right?
I think so, yeah.
I knew we have had that.
I always love the look on the face when we lose her too. So
yeah, isn't that pretty, guys? You can see that. Yeah, she's having internet issues probably wherever she's at.
It was great. And what was I supposed to stop?
She is.
Yeah, you were in a.
I paused.
You were doing nothing.
Yeah.
Yeah.
Oh, okay. Well, did I say, yeah, I'll go back and do it
Nothing.
again?
Yeah, start from the beginning.
Yeah.
So I admit it, I sounded so good and professional. Yeah, everybody's a little worried about my internet.
Let's each one of us read each of these. How about that? And we'll
That's
start.
a good idea. Okay, I already started the first one, so I know I can do it right. So I'm gonna, I had a practice run already. So Elsa said that I'm very happy that I came across CCO when researching which was the best route to help gain knowledge in medical coding. The education provided was great, and the instructors have a great way of presenting the information. That's Jennifer and I loved that I had access to the course 24/7, and then I could work at my own pace. This course is highly recommended by me, and I look forward to continue taking courses through CCO. And what I had said before, I don't know if it went through, but these are all really, really current ones. Boyd pulls out the most recent ones, so we get these all the time. These aren't like old ones from last year or anything.
Go ahead, Jennifer.
Well, that was actually Melinda, so I'm going to do Elsa now. So Elsa passed the CRC exam with an 84% on the first try. That is awesome. So thanks to Alicia and Chandra for their wonderful CRC course and the Blitz. She is a member of the CCO Prime and ready to rinse and repeat. So this is the very first venture into medical coding. So any ideas on which class to take next is greatly appreciated. Guess it depends on what you want to do. So.
And Tyler said on May 10th, being able to apply the BAT technique to my CPT book was the single most important thing to keeping myself on time through my CPC exam. The questions are sometimes lengthy, and to be able to knock out a couple of answers immediately just by recognizing that this is an X-ray code and the question asked for a CT code is extremely helpful. I feel like if the XR and CT letters circled next to the codes weren't there, I would have struggled to finish on time. I know this seems trivial, but it matters. Of course, this is only one example of how BAT helped me. In my opinion, you'd be crazy not to apply the BAT method to your manuals. I was able to pass my CPC exam with an 86%.
Awesome.
That's great. That's
very
really
good. Yes.
So again, these reviews just help us, translate that you're not the only people who are out there, taking the courses, but there's a lot of people are getting value from these, and encourage you to check them out as well.
Yay.
Q&A.
So we're
then we get to these prepared
officially
questions.
ready to start.
Yeah.
I get to go first. Woo!
Yay!
That's because they're worried about my internet. No, I'm just kidding. Like I said before, May is National Hepatitis Awareness Month, and we were thinking it's really important that when you're coding hepatitis, that you understand the disease process and what organs are affected. So I decided to start with the liver, and let me just pull this answer sheet over This was a lot of fun to do, but of course I'm a real nut for the disease process anyway. I'm going to just change this, make this a little bit easier to see. The CDC put out this tagline about May being the awareness month, and May 19th was National Hepatitis Testing Day. That doesn't mean you can't still go out and do it, but hepatitis is something that's transmittable. So it is something the CDC is careful to talk about and make sure people have an understanding about it. So let's talk about the liver, because actually hepatitis is an inflammation of the liver, but a lot of things can happen to cause that. And it's real important that if you want to understand the signs and symptoms, then you got to know what the liver's function actually is. So these are the main things you need to know about the liver itself. One, it's the largest organ inside the body. Now the skin is the largest organ of the body, but the largest organ inside the body is the liver. It assists in digestion. A lot of people don't realize that, because you think it has to be part of the stomach and intestines, but it assists in digestion. It stores energy for our body. It actually is a filter and removes poisons from the body. That means it also filters medication that you take. It gets processed with the liver. Hepatitis, again, inflammation of the liver, that's what it is. And most of the time, if you have an inflammation of the liver, it's due to a virus. Now, that doesn't mean you can't have a virus that caused the inflammation and also get an infection, but it's usually a virus that has made the liver irritated. With that all being said, here's the anatomy. The liver, and just with the limited amount of stuff that I put on here, it's actually a fascinating organ. When people have a liver transplant, because I didn't even touch on that, they can take just a portion of a liver and put it into somebody's body, and it will kind of grow to maximize and meet the need of the body. So that's pretty fascinating too. So the main part of the liver here, it's important to know that it's very soft. It's just like a cow's liver. If you've ever gone to the grocery store and bought in the little white tub a cow's liver, or if you've ever butchered, I don't know, maybe some of you guys have, but it's very, very soft, and you could like pinch it and break it. The gallbladder sits kind of right under the liver. So if you've ever watched the procedure of a gallbladder being taken out, or even appendix is down lower, but they have to lift up the liver and push it up out of the way to be able to get to those organs, like the pancreas, the gallbladder, and actually the stomach, because there's the duodenum, and that the stomach is right above that. So again, this is what the liver looks like. I think most of us know what the liver looks like, though. We learned it in probably anatomy classes in high school or even junior high. The main types of hepatitis have a letter associated with them, and A through E, there's that many viral hepatitises. Now, I didn't want to spend a whole lot of time. I mean, we could talk for a very long time, or at least I could, about hepatitis and all these different types of viral hepatitis. The ones that you hear about the most, though, are A and probably C. So hepatitis A, what makes it unique is that it usually is an acute attack, and that it can, once you get treatment, it can go away. You can get a vaccine for it, and a lot of times the way that it's acquired is through an infected person's stools, and another person touches that. So this could be someone that is a caregiver, right? A nurse or a home caregiver, might be cleaning people up or something like that. B, though, is acute or chronic infections, and you need screenings to find out if you've been infected with B. Always worried about women who are pregnant and hepatitis B. C, also acute or chronic, but C is one that if you were born between 1945 and 1965, you have a higher chance of getting hepatitis C. So look into that a little bit more to find out why. Didn't want to get all the details and stuff. Hep D is unusual. It is one that you probably don't see as often, but it's usually happens to a person that got hepatitis B and then they get hepatitis D. It's a super infection. And then E is usually always an acute infection, and usually gets better even without treatment after several weeks. Okay, you let the body kind of regulate itself. A lot of times you get it from eating something that was contaminated. So that could be pork, or even wild animals. Now, those are the ones that we usually talk about. And when you're a coder, when a person is diagnosed with hepatitis, it's going to tell you need to go back and get one of those A or B codes to determine, if it's one of these types of viral hepatitis. There's also an autoimmune hepatitis. And what happens with autoimmune hepatitis is that your body's natural autoimmune cells go in and start attacking the liver cells, thinking that it's a foreign entity in the body. And so it starts breaking down the liver cells and irritating the liver. This is usually caused by another disease or another autoimmune disease, or having a problem with your immune system. The main diseases that can trigger this autoimmune hepatitis, and remember, hepatitis is an inflammation of the liver. So when you say autoimmune hepatitis, that means anything that's autoimmune means that your body's attacking itself. So all of these other diseases that we're listing here are your body attacking itself. And again, they could also attack other organs, thus the liver, thus hepatitis. So you've probably heard of these. If you haven't, it's probably a good idea to do a little check on these and refresh your memory. If anything else, just to know the signs and symptoms. But Graves' disease, IBD, rheumatoid arthritis, definitely an autoimmune disorder, scleroderma, I think that's called Sojourn's syndrome. I never know if I'm supposed to be making one of those letters silent when you see the little umlaut. There's a specific type of lupus, which is SLE. It's called systemic lupus erythematosus, thyroiditis, which is an inflammation of the thyroid, and type 1 diabetes and ulcerative colitis. Now, notice that some of these actually affect other endocrine type body parts, like diabetes. Type 1 diabetes affects the pancreas, and as well as thyroid. So these are endocrine systems that are affected. So one of the things that was interesting to note is that usually autoimmune hepatitis ends up affecting women, young girls and women, and there can be a genetic factor there, which with autoimmune diseases, a lot of times genetics plays a part. In addition, drug-induced hepatitis. Now, if you're familiar with the way other diseases work, like diabetes and all the different types of diabetes that you can have, type 1, type 2, you can also have idiopathic and et cetera, stuff that's secondary diabetes. That's kind of like what we're talking about with drug-induced hepatitis. So you take a medication and it injures the liver. It damages the liver. For the most part, we would think, oh, well, of course there's medications out there that are going to bother the liver or other organs. And we know that NSAIDs, things like ibuprofen and stuff, they can be very harsh on the liver because the liver processes that, right? Processes poisons and things that you take in. But you may not be aware that of some of these others. And so I thought that was pretty worthy of mentioning. Birth control pills, erythromycin, which is an antibiotic. And you notice there is, I think there's another antibiotic on here. Tetracycline's antibiotic, specific type of amoxicillin, and anti-seizure medication medication. So my son that has epilepsy, that's on 3 seizure medications, he has to go have his liver functions tested all the time. But you may not realize that some over-the-counter medications are extremely hard on the liver. We used to be really concerned in the ER when people had overdosed on over-the-counter medications like Tylenol and taken a whole bottle of Tylenol, because for the most part, you think, well, it's going to eat, you know, it's not going to hurt you too much, but it'll actually ruin your liver. And so they were very worried about that. Just some other types of hepatitis. We have alcoholic hepatitis. If you drink too much alcohol, your body is filtering that poison, and it gets irritated and you get cirrhosis of the liver, which is kind of like scar tissue that builds up. Iron overload as well. That's why it's iron pills used to be regulated, because if you take an overdose of iron pills, you can destroy your liver, damage your liver. And fatty liver. Now, fatty liver is something that can come with obesity, but it also can be genetic. So a lot of people in my family that aren't fat, just a lot of people in general, they have fatty livers, and when they go in and do a surgery like take your gallbladder out, they'll mention that. Last, if you want to know more about how they test for hepatitis, it's an ALT, A-L-T, and some of these other types of testing that's done to find out if the liver is damaged or not working at peak capacity. And we're going to talk about that on another slide. There we go.
Thank you, Alicia. Very, very, very much. And this slide is about our survey. So I thought I'd include this slide up at the beginning and give you guys a chance to kind of watch the webinar. And for those who have maybe been on the webinar before, maybe you already have some thoughts. But this is basically the link that I'm going to post now in the chat. So if you just click on that, keep it open, or just fill it out if you already have some thoughts. We'll come back to this a little bit later, but we want your feedback to make our webinars a little bit better. If you got some more poll questions or things like that you think that we need to revise our questions, I'd love to hear about them. And maybe some special guests, maybe if anybody who can nominate maybe a special guest that they thought would be great to be interviewed during a webinar, that'd be awesome too as well.
Yeah.
Okay, so that's just a thought there, all right? So we got Jennifer as the next one.
Let me get rid of my camera real quick, and I'll move it over for you.
We had a question come in asking about coding and billing with the CPT and diagnosis codes for the well woman visit, physicals, GYN, and pap smear screenings for the commercial and Medicare patients. I'm going to preempt you here. I forgot the diagnosis code when I did this. I was like, oh, darn, I knew there was something else. So I actually, there's a problem when you say a well visit. So a lot of people, there's different terms out there. So especially, you think of the well visits, the preventative service visit, which is in the family codes of 99381 to 99397. So for new and established, and those are based upon the age of the patient that you see. But Medicare has a different terminology. So we're going to start with Medicare, since that was one of the areas that they wanted to look at. So I'm going to say I just went to a Medicare symposium. It was held in Delaware the past 2 days. It's a free event, and I earned 12 AAPC CEUs, and the knowledge was just wonderful, and this is actually one of the things that they talked about. So your local MAC carrier has these symposiums and webinars and stuff, so they're really good information. So this, of course, is all on Medicare website, and I have a lot of links in here too. So preventative visit, when you're dealing with Medicare, they have what's called a welcome to Medicare visit. So this is an IPPE, in the initial preventive physical exam. So within the first 12 months of a patient receiving their Medicare acceptance, so on their card, there's an effective date, right? So that within the first 12 months of their Part B effective date, they can see their provider for an IPPE. And there are specific things that are to be done at these visits. So it's actually intended as to review the patient's health. Now, perhaps they haven't been to the doctor in many years, or perhaps they come all the time, but they also are reviewing what's available to them as a Medicare patient now. So now they have Medicare. Things are different. It's not the same world that they had with their previous insurance carrier. So these are for the 65 and older Medicare, because sometimes you have people who are disabled on Medicare. So this is, or we're talking 65 and older patients. So there's actually, when you go through that and you tell them about all the screenings that you can have on Medicare, and you go through their health and kind of assess their health is what you're doing, there's a specific code for that, and that's G0402. That is a one-time only code, and it is to be used within the first 12 months of that patient getting Medicare. So if they come 14 months after they get Medicare, you're doing a totally different code. So it's only the first 12. That link there is specifically for the IPPE. So Medicare has all of these little worksheets out there, little booklets, little pamphlets of information, and this one is specific for the IPPE. So the IPPE is the initial in the first 12 months. Now, when we talk about a wellness visit, that's what Medicare refers to their other set of visits that they offer for Medicare. So is a wellness visit. And that's updating that information that they did from the first one. But what if the patient never came to the first one and they, never visited and got that initial welcome visit? That's okay. At their first initial wellness visit, they'll go over some of that as well. And this is after they've had Medicare for 12 months. They can get this initial one. So the initial one is, again, a one-time only code, G0438. They can now have every 12 months another wellness visit, G0439, and that's their annual wellness visit, AWV, and that's another education pamphlet that they have a link to there. And all of this, just go under CMS and plug in AWV, plug in IPPE, and you're going to get this information, or your local MAC carrier as well. Now, Medicare Advantage is one of the United Healthcare Medicare Advantage plans, talked about specifically the 99387 and the 99397. So 99387 is a new patient 65 and older preventative exam. And 99397 is established 65 and older preventative exam. Now remember, this is the description in CPT. Periodic comprehensive preventative medical re-evaluation and management of an individual according to their age, so the age and gender appropriate history, examination, counseling, and other risk factor guidance, reduction, intervention, and ordering labs. So it's either new or established 65 and older. So that's the description in CPT. So we need to remember here, what is this E&M code doing? Evaluation and management, which includes a history, examination, and counseling. So the purpose of a routine annual physical exam is to provide that physical examination looking for a disease or promoting a healthy lifestyle and assessing the risk factors. And so you think, well, wait a minute, that's what we just talked about in the annual wellness visit, is looking at their risk factors, assessing the patient's health. However, this is giving an examination. So they're physically examining the patient. In an IPPE and a wellness visit, they are not examining the patient. They're assessing the patient with all of their diseases, all of their medications, how they live. Do they live by themselves? Do they eat well? Do they, can they drive? All those types of things go into a patient's health. So if they have nobody to take them somewhere, that's going to, of course, go into how well their health could be down the line. So that's the difference here. If they're doing an actual physical examination. So the wellness visit, the GO 438 that we did, and a comprehensive preventative examination, they are completely separate codes. They're not the same thing. They don't mean the same thing because that preventative exam includes an examination. So they're not to be used interchangeably. That's not what they mean. So if you bill that 99397, just know that's not a covered service for Medicare. So after they turn 65, they don't really get those examinations anymore where you go and have that physical, that examination. So they can be billed together, but the patient should be aware that, yeah, I'm going to examine you. You came here for an examination. That's not covered by your insurance. So here, I got this lovely little form. It's called an ABN, an Advanced Beneficiary Notice. I'm going to have you sign it because this is not a covered service, and you will be responsible for payment if this is what you would like to do. So they need to be aware that it's something totally different. They are going to be responsible for it. And the physician, if you are going to provide that service along with one of these other well services, then they must be documented properly. So you need to make sure the documentation's kind of separate. You need to make sure one's showing their assessment, and this is what we found on the physical exam. So also we talked about, PAP and pelvic examinations. So there are specific codes for that in our HCPCS codes. We have PAP and pelvic exams, which may include a breast exam. Medicare patients are allowed to have them every 24 months, every 12 months if they're a high-risk patient. So there's all different kinds of HCPCS and CPT codes that, I'm sorry, I said CPT, but they're HCPCS codes that could be submitted to the insurance carrier. I didn't list them all because there's multiple, but a PAP and pelvic screening has, again, another brochure specifically for PAP and pelvic screenings with those diagnoses to include the high risk. What is a high risk diagnosis? What codes can you bill? And that just depended upon the exact service that you provided to the patient. Now, in a commercial carrier, we go back to that list of preventative codes that we had because we're talking well woman, which could be any age. So we asked Medicare, and that in Medicare, we're talking over 65. A commercial carrier, for the well preventative examinations, that annual physical examination that we're going to have done, that service is going to include a pelvic examination because you're examining, remember, you're examining all your different body systems. So a pelvic exam is one of those systems that will be examined in a preventative medicine code. So some carriers may have restrictions on how often you can submit them or how often a patient can have them, or a specific diagnosis code that they want to have, whether it's the, off the top of my head, is it Z87.9 for, off the top of my head, I'm sorry, I didn't give the diagnosis code. So if they have a screening PAP, so they came in for this preventative service and they did a pelvic exam, well, they also need a pap smear. So if that is done for a screening PAP during that preventative visit, we're going to do the Q0091, and most commercial carriers do pay that code. However, if the patient came in for another issue and you're billing a regular E&M, some kind of illness or injury or some other kind of acute problem, and you wind up doing a pap smear, that is not Q0091 because that is a screening pap test, a screening pap smear. So if they came in for an illness or an injury or other problem and you wind up doing a pap smear, there's a different code for that. So you don't do that Q code because that's for screening. So you're going to be in the laboratory codes, the 8800 codes, in your 80,000 series for laboratory. And that's collecting a pap smear. So you'll go into this, it'll make a little bit more sense when I get into my next one about laboratory, but that's a laboratory code for performing the pap smear. So a physician is not going to bill that code because they didn't perform that test. They take that swab and everything and they send it out. So all they did was collect it. So you're not billing an 80,000 code either when you do the pap smear. So you got to remember some things that are inclusive, those examinations and such, they would include that pelvic exam that you're going to do. And that's sometimes where a lot of these things get a little bit confusing, especially when you're talking those Medicare patients in that 65. So I highly suggest, I'm going to give a little tips here. My local MAC is Novitas. So Novitas is in 10 of the 50 states. So if you're in any of those 10 states that have Novitas as your local MAC carrier, you have access to, I like to call it Vitasphere because it flows much better, but apparently it's Novitasphere, which it doesn't sound right, doesn't flow right. On Vitasphere, I highly suggest if you're part of Novitas, and I do believe all the other MAC carriers have this online requirement because CMS requires it. So you should have an online portal. And on this online portal, they have tabs for the patient that you've entered their patient information. It's going to tell you when that last preventative visit was. It's going to tell you when their last pap smear was. So if you are a primary care provider and you deal with this often with elderly patients, it's going to have all that information there. If you deal in radiology, it's going to tell you when their last mammogram was. Any of the screening services that are available as preventive services for Medicare patients are on that MAC portal. So I highly suggest somebody in your office or your facility having access to that portal because that will save you a lot of time, unnecessary ABNs or the patient, or you can just say, you know what, if you wait 2 more weeks, you'll be at that year. Remember, you're close to a year, but if you come back in 2 weeks, Medicare will pay for this service for you. So it's another tip I just learned, but everything is on that online portal. So it's a really good tool if you deal with a lot of Medicare patients.
Yay! That was excellent.
Thank you,
That's
Jennifer.
really good stuff.
You're welcome.
All right. Hey, I know some of you already got a message about this. I saw some of you commenting on it. And yes, the CCO Club Prime is closing for new students. And on May 28th, which I think is Tuesday, right? Didn't we say that was Tuesday, Jennifer? It'll only be available privately or for the returning students that have purchased a course in the past. So from that point going forward, you need to be a student, a regular student, before you can go into CCO Prime. If you have any questions about this, we have an FAQ on the website, and you can go to the cco.us/club and get all of your questions answered. But heads up, we wanted to let you know time's running out on being a new Club Prime member. All right.
Next slide shows the current prices, I believe, or unless they got taken out. Oh, actually,
I think it got taken out.
I think you didn't refresh your slide deck. That's all. Don't worry about it. Don't worry about it. Just keep going.
Good, because then I get to talk again. But you guys just go to the FAQ, and it's got over there on the website. If you have any questions, it should be all answered right there. The next question that we had, coding liver tests. This is one that we both were excited about. Jennifer and I both had ended up answering this. What is the most appropriate way to code elevated liver tests versus elevated liver enzymes? So here we go. I found this a lot of fun, but of course it plays right in to the hepatitis, right? So the fact is that the code that you're going to use is R94.5. But I understand why this is misleading, and it has to do just with the verbiage. So elevated liver test is really the same as an elevated liver enzymes. They're synonymous because it means that they've tested the liver, and the liver has an abnormal test result. Doesn't matter what it is. The key here for you, though, is the CPT code. Now, I know they were specifically asking about the ICD code, all right? And the correct answer is R94.5. But pay attention, and I'm going to tell you why. There are individual lab tests for the liver, like liver enzymes, okay, and other tests that they can do individually where they can do a panel. Excuse me. If they do a panel, then of course several will be listed in there. Heads up, got to be careful with that, okay? So what is the test that's commonly done that you're going to see in the lab work that's going to give you those results of either elevated liver enzymes or a elevated liver test, kind of making that more broad? It's that ALT test that I told you about before when we were talking about hepatitis and the different types of hepatitis. We don't have to worry about the range, right, as coders, but some of you may be clinicians and you may already know what the normal range is. So just per your knowledge, as we're increasing your knowledge base, you can have a lab test value of 7 to 55. And men and women, little bit different. So men can get a little higher than women, but these are normal tests. If you're in the range of 7 to 55, then you're probably good, and it wouldn't be considered an abnormal test. What do they usually do? Well, the ALT can be done by itself, but it's usually done as a panel, because if you have something wrong with your liver, this is going to show it. The ALT is going to say, hey, something's up, you know, that liver is irritated, thus hepatitis, right? But we need more information to see what is the function of the liver or any other comorbidities that's going on that could cause the liver to do that. So again, panels are set up. If you do a panel, you might see them doing an AST test, which is a liver enzyme test, right? See how that's a little more specific? And then they'll do the ALT as well, usually. So again, the doctor will compare them and find out what the issue was. I just got this off of WebMD. I go out to Mayo Clinic a lot too, and you can check those. I footnoted them for you. So I thought this was very interesting and good for your knowledge base as well. If you just have a slightly higher ALT, it would still be abnormal, but it's just slightly. Some of the conditions that would cause that would be the alcohol abuse, because we talked about, you know, alcoholic hepatitis, and we know that alcohol is hard on the liver and can cause cirrhosis, which cirrhosis is that scarring and damage of the liver. Mononucleosis, which is, you know, the kissing disease, mono. You've probably heard of that. I actually got mono right before I started my freshman year of high school. I missed the first 2 weeks of high school. And also statins and aspirins and other types of sleep aids can irritate the liver and cause you to have an elevated, just slightly elevation there. Now, if we get into moderate levels that are higher of the ALT, it could be things like chronic liver damage. There's something chronic going on with the liver. Of course, alcohol abuse, cirrhosis. Maybe your bile duct has stones in it and there's some type of blockage. You could actually have a heart attack or heart failure, because if you didn't know, if you study cardiac issues, which I love to do, the organs start to fail or struggle as well, which will indicate that there's a problem with the heart, and the liver is one of those indicators. Kidney damage, whenever you mess with the kidneys, if the kidney has problems, other organs start to fail. Muscle injury, did you know that? Muscle injury, because the body is filtering the damage, the shock of the muscles. Red cells, anytime you have a problem with the red cells, then red blood cells, heat stroke, but that wasn't on your list of thinking that that could cause a problem to the liver. And also too much vitamin A, which again, we're looking at things like iron, right? Now, for it to be very, very high, a high abnormal, then we've got usually a sudden onset of hepatitis, usually viral, and then you could have an overdose of a medication, specifically Tylenol. Remember I told you that we'd have people come into the ER that had either intentionally or unintentionally overdosed on Tylenol, which you would think that wasn't a big thing, and it doesn't usually show a side effect right away. But if you find out they've taken too much Tylenol, that maybe they used a sleep aid to, you know, if they were intending self-harm and they use like Tylenol PM, the Tylenol is actually more dangerous than the Benadryl that's in there. The Benadryl can suppress your breathing, but the Tylenol will destroy your liver very quickly, unfortunately. And then, of course, liver cancer, right? So what is the way that we would code? We're going to code the R94.5. That's the ICD code for anything that's abnormal with the test of the liver. Doesn't matter what the verbiage says. And then be very, very careful though with the CPT code that you understand, hey, are they doing a panel or are they doing an individual test by itself? This is such fun stuff. All right, moving right along, guys. We get another poll.
Which area do you feel you need more education in? Is it billing? Is it CPT? Is it ICD? Is it especially credentials? And which one? Please write in the question box. Or is it something else? Either way, let us know with a little bit more details also once you make a vote there on the survey. We always like to know how we can help you. If there's something specific in billing that also helps, you know, something that maybe you're not finding out there in the marketplace that we can help with. We always like to take the feedback from our audience.
Hey, that was really pretty sounding.
That is
Especially
my ring doorbell saying somebody's walking through our front yard where we don't have a gate yet. So yeah.
well, especially going right at the end of the poll. It was kind of
Yeah, I was like, whoa, ding, ding, ding.
Worked perfectly.
Yeah, I didn't plan it. Trust me.
Good timing.
All right, here we go. Closing and sharing. Billing says 23%. CPT, more CPT, huh? 40%. ICD 18. Specialty credentials. Which ones? What do we got there, Alicia, in the chat? 15%.
Hey, I see CPT guidelines, which we do that specifically on the Blitz, by the way. Neurosurgical billing. Ooh, I like that. And Maria is saying that I'm an IT specialist going into medical billing and coding as a new career. You know what? There is a huge demand for coders that have IT backgrounds because of creating EMRs. Definitely go into the CCO club and mention that, because we've talked about that quite a bit. Some fascinating careers that you could do that together, that background knowledge. Really great.
oh yeah, yeah.
Good stuff. Ooh, okay, let me get my camera off here. And
Okay, so my question, this was presented on one of our webinars we did a couple weeks ago in the evening, and somebody had said that they work for an independent lab and they're getting denials for the G0483 billed along with the 80307 place of service 11 because the specimen was collected at the physician's office. So should they use a modifier? And they'll appreciate the input. So when you're dealing with labs, you know, I think a lot of people go, ooh, lab, I don't want to deal with that. So we're looking at these codes. So the types of codes that they gave, 80307 and the other one, oops, sorry. So there are presumptive and definitive. So when you're looking at a presumptive procedure, that is used to identify a possible use or non-use of a drug. So they want to see if there is presence there of a drug, any kind. So a presumptive, it can be followed by a definitive in order to specifically identify that drug. So they did a presumptive, they said, yes, there is some kind of drug in the system. Now we send it off for a definitive, and depending upon which code you use is how many classes of drugs they're looking for. So that test is going to identify the specific drug or metabolite if they perform it. So you don't have to do the presumptive to get to the definitive. And it could be sometimes people who are on your pain management protocols, you already know there's going to be a drug in their system because they're on pain management. So you want to see which drugs perhaps. You might skip straight to the definitive. So you don't always have to do that presumptive. So when we looked at the 80307, that is a presumptive test of any number of drug classes. So it doesn't matter which one you're looking for, and it's any number of devices or procedures. Now there isn't this is the third level of the code. So 80307 is the highest level because you're doing it by this chemistry analyzers. The other ones you're just looking at. You could, like a dipstick would be one of the examples they would use. So this is the higher you're using analyzer. You're using the equipment in the laboratory to figure it out. So that includes the sample validation when it's performed, and it's per data service. So according to CPT, you can use this for any number of devices or procedures. So you're reusing that sample. It could be used on a couple different machines or something, but it's all one code. So you report it once, no matter what drug classes you're looking for, and it does include that sample validation when it's performed. So some things to remember. I know it says it in the code, but they actually have it in the guidelines as well. So I know some people might look over. This actually description was much longer than that because it included all of those types of machines too. So it was I abridged it a little bit. The G0483, again, is a level of the code. There's a family there, and that's drug test definitive, where you're looking for a drug identification method to identify the individual drug and distinguish it between different structures. You know, some of them may have the same makeup. I really hated organic chemistry. Stable isotope or other universally recognized internal standards. And then the method or drug specific calibration or matrix quality material. You're looking at your control substance. So it's quantitative or qualitative, all sources, including specimens. So like I said, per day. So like I said, there's different levels. This one's looking for 22 or more drug classes. So one of the other codes, G0481 and G0482, they're looking for different numbers of drug classes. So when we look at Medicare, you're going to perform providers performing that validity test on the urine specimens utilized do not bill for that. So a lot of times a provider may take a sample, do their own test, bill for it, and then say, oh yeah, there's something here, let me send it out. Now there's a specific reason for that, because it can only be billed once. And it doesn't matter who gets there first. So that could be what has some of these errors coming through. So if the office billed that same 80307 code for some reason, or 80305, anything in that family, then that code might have gotten there first. So it creates a denial for the laboratory then. So sometimes they might do their own. So not knowing if this was a Medicare question or commercial, I tried to find some other sources, and Blue Cross Oklahoma had a policy out there that's saying that the testing is not appropriate for every specimen and shouldn't be done routinely. So a lot of times a physician is just saying, oh, send it for presumptive and definitive. Well, a lot of times the definitive isn't done unless you find something under presumptive. So you have to have something tell you, yes, there is a presence there for you to do this. You can't just routinely order them. So that could be causing a problem as well. So it should be performed in a setting of unexpected results, meaning someplace else, not in your office, unless you have the equipment to do all this in your office. And the rationale must be supported by that documentation. So your insurance carrier is still going to ask for documentation of why did you want a definitive test done? Well, just because is usually not a good enough answer. So you have to show that there was something there first in order to order that second definitive test. So example, they're looking for something in there, or if you already know the patient's taking a medication or a drug, then you usually aren't going to do that presumptive. You're going to go straight to the definitive. Now, Medicare says that to receive reimbursement for that, for testing, the service has to be reported on the claim, must match what's ordered by the physician, of course. You know, some of these things make sense, you know, like why do you put instructions on shampoo, but it's still there anyways. You think it would make sense to most people, but not always. The incidental findings are not a covered service. It could be denied. So if it didn't have a reason for doing it, you can have one per data service, one presumptive and one definitive per data service. And the data service is the data was collected. So just so you don't say, well, it didn't arrive till the next day, I'll bill it the next day, just to offset what a physician might have done. No, the data service for this is the data was collected. So that could cause some problems as well if you're billing different dates or, you know, billing multiple of the same code, because it's one per data service. And it's rather small, but rather typing all of this out. This was a cut and paste directly from CMS, and I did provide the link for this coverage determination. So it's non-covered in those 10 cases. So in, again, it is repeating some of the same things. If it's done at one place already, it's not going to be paid for again. So it's non-covered. It's non-covered if you didn't have an order. It's non-covered if you didn't have a reason, if it's not medically necessary, of course. So when we looked at place of service, you know, they said, well, this is an 11. And that's where I found some other arguments out there on AAPC and some other sites, is people saying, well, isn't it supposed to be an 81? I can get it paid if I put the lab place of service in there and not the 11 place of service, which is an office. But the place of service and the directly from Medicare Processing Manual, which is like my Bible. I have a bookmark on my screen, and Medicare thought I was crazy when I said I read it every day, but I really am in there every day. So they're like, no, you aren't. I said, yes, I am. So if that physician bills for a lab service furnished by an independent lab, and this person was in an independent lab, then the CMS form is filled out for the place where the sample was taken. So a lot of people say, well, if you bill 81, then you can get it paid. But the patient didn't go to the independent lab and provide that sample. It was done in the office. So it has to be that 11. And that's where, or if you're in a hospital, 21 or whatever it is, but you only bill the 81 lab service if it was actually done at the lab. So if it's done in the office, which they said in the question, that was the case here, that it's place of service 11. So you have to use the place of service 11, and you're using those two other codes. So my only suggestion is the problem could be because I could not find any reason out there, and I don't search this 24 hours a day, but I was searching it quite often, trying to look in all different sources for an answer. And the only suggestion I would have is if that physician as well billed for that service. So that's the only way I could see an error happening. Now, there were forums out there where people said, I'm having that problem as well. So it's possible that's what's happening. And if this laboratory sees this often, Is it the same physician doing it? Perhaps now the physician is misbilling. Perhaps somebody in their office doesn't understand the coding for it. And also, if they do the dipstick or something like that there, then some of those guidelines have indicated that that makes the laboratory's test invalid. So it can't have any other substances in their test sample. So that would make their, that they are not able to bill for their sample because it would now be invalid. So it's possible that that's the only thing I could find where these errors might be coming from, is the physician's office that provided where the patient was at giving the sample is also billing for that same code. And then it's first come, first serve. So whichever one got there first, that's where it's going to create a denial. So that's the only thing I could find. So.
Wow, everybody's eating that up. They're asking lots of questions about that. Woohoo!
Oh, really?
Yeah, they like that one.
Okay. And laboratory is not something I normally deal with, so that was I learned a lot in that one. So
and
yeah.
Lab, path and lab is where a lot of people struggle when they test too. It seems like when people get the feedback of where they scored lower, it's usually path and lab. So, you know, not that they're going to be doing these particular things we just talked about, but I think it's just not on everybody's radar. Maybe. Here's the survey again, that link that Boyd told you about earlier. So please take that link down and give us a survey, give us feedback. We really truly appreciate the feedback that you give us, and we want to provide a good service to you. So again, if there's something that you think that you would enjoy or that we could improve upon, then and make these webinars even better, you let us know. We would appreciate it. And now we're going to talk about pre-op chest x-rays. The question that came in was, would a pre-op chest x-ray go to Z01.811? I'm coding for the radiologist. Well, this is pretty quick. This is going to be a pretty easy one to go through. Although that never stops me from putting a lot of information on a slide thing. Okay, so it does matter if it's the radiologist versus somebody else sometimes. Okay, you know, like an ER or even a doctor's office that's having this done. And she did specifically say that she was coding for the radiologist, but I'll tell you why this will, once I show you, everybody's going to go, aha, it is there. It's actually answered in your manuals around the code. So what is the Z01.811? Well, it is a health examination code. And I went ahead and pulled out a list of the following that are considered examination codes. And if you look here, we've got, and again, like Jennifer said earlier, I didn't make this really, really big, or it would just be scanning through this, because you can go get this list too. Just Google it. So again, this is a Z01 code, and that falls under other special examinations without complaint, suspected or reported diagnosis. Okay, and again, why are we doing an X-ray for pre-op? It's usually to make sure the patient's healthy enough to have the procedure done. And so that's what we're doing. We don't have a complaint. We don't think anything's really wrong. We just want to make sure there's nothing wrong before they go in and have this procedure. And a lot of times anesthesiologists want this. However, they have to have a reason why they would think that you would need a chest x-ray before a procedure, because a perfectly healthy person, and they're just going to go in and have something routine, or even say, well, something that's planned because it's a pre-op visit, that there's no reason to do a chest x-ray, right? So this was in the notes. There are other codes to describe whenever we're going to do a pre-procedural examination. And now this is a note right there under the code Z01.81. So if you look that up in your manual, you're going to see this note written there. It's usually in smaller print down at the bottom, and it says, especially, look, I made it in bold, Z01.81, and there's more characters, special screening examinations. Okay, so there could be other codes for pre-procedural, but it says specifically for this code, Z, the one we're talking about, preoperative examinations are for encounter for radiological and imaging examinations as part of pre-procedural examination. That's the code. That's, I mean, you can't get much more of a definition than that. In addition, I did find this on a particular website, and I footnoted the website for you, but because this was a person writing an article about reasons why you would have a chest x-ray and reasons why it may not be necessary to have a chest x-ray. I mean, it's okay to ask your provider, why do you want me to have a chest x-ray before the procedure? And then they'll tell you why. There's nothing wrong with questioning it. So, you know, in your mind, you don't think they're just doing all this stuff for a reason, but there's got to be a reason or some type of a protocol in place why it would be done. Maybe you have a sign or symptom of something to do with your heart or your lung, because when they do a chest x-ray, it's not just the lungs that they're looking at. They're looking at the upper thoracic cavity, you know, and so it's the lungs and the heart that can show something. Maybe you have some of these other signs and symptoms, and you may not realize, but swelling of the ankles could be a reason for CHF. I happen to be in a doctor's office waiting room with my husband for an ENT appointment today, and there were two elderly ladies sitting next to each other. One was very petite and slender. They were obviously friends and probably the same age. And the other lady was pretty much the same size, but her ankles were extremely swollen. And I thought, okay, she's got CHF, you know, because that's what that tells me in my brain. And so again, something that we may not think about or could be a reason why the provider is saying, you know what, we need to do another test. A lot of times it's just basic protocol if the patient is of extreme age and being over 70. And then also if you're having something done, the procedures to your heart or lungs, then of course it makes sense. We need to go in and look at that. But I thought I should let you know that that particular code is for when we don't think there's another condition going on. Okay, we're just doing a pre-op to clear that the lungs, heart, everything in the chest is okay for surgery. And it doesn't always have to be just for anesthesia. Okay, just keep that in mind, because a lot of times people think that. But if in fact there is another condition, something going on, then you capture that other diagnosis code. Maybe they do have CHF. Maybe they do recently have a fever, you know, and so whether they suspect something or not could mean a different diagnosis code. So that's something that we don't think about when we look at that. And remember, because this states right here, without complaint, suspected or reported diagnosis. Now, if the patient has CHF and they're having a preoperative exam, a chest x-ray, then you're just going to code the CHF. That's why they're having it done, is to clear them for surgery. This is without complaint. Okay, so I want to bring that to your attention. Sometimes it's all in the fine wording. And that's it. Yay, we're doing so good with time. Boyd is so proud of us. I just know he is.
Thank you, Alicia.
Yay.
Another shout out to the CCO Club there in that slide. And I think we've gone over this enough tonight, so I think we've drilled it into people's head, the value of this. Earning
think so too.
CEUs, webinar and support call replays, billing, coding, Q&As, extended product support. Also, the answer sheets from tonight's webinars are also in there as well.
Just more information about the CCO Club Prime. Like I said, just that same link that was on the previous slide Boyd just said, all the FAQs and information's about that if you want an update, because I know some of you guys got that email. So.
Yep.
Okay.
Awesome.
This price will be changing probably, so
I think it
pay
already
attention
has.
to that.
I think that's an old slide.
Okay.
All right.
Yeah.
So we have a winner, and I'm pleased to announce that the beautiful, the wonderful Lisa Gay has won. And Elisa, you can just say, hey, I'm here in the chat and make sure that we're here. And then you have a choice of either a Blitz video package, 1 year of CCO Club Basic, or a 1 hour session with Alicia.
Whoop, whoop. Jennifer would probably.
Or I take. I get free hours with Alicia all the time.
Yeah, we talk a lot.
Alicia likes to talk more, so
Yeah.
We were trying to figure out the other day. I was telling Boyd, I said, you know what? We're getting close to like a decade of knowing each other. He goes, no, it's not that far. I was like, no, it's like 8 years. So I mean, to me, that's really close to a decade. We're moving right along.
Yep.
Just round it up.
Yeah. Okay, that's about the CC user certificate. We are ready to. Was there anything else that we need to do before we go to the questions?
No, I said go for it.
Okay, I'm going to pull these over. Thanks, guys, for giving the questions.
Hopefully you still got 3 there. Yep.
Yep, I do. They were worried. They were chatting in the background saying, make sure you refresh and everything. So let me just move this.
I pulled it up just in case.
Yeah, she did. Nobody knows our sorrows when it comes to my internet as much as the behind the scenes guys. Okay, I can do that.
No reason not to, I don't think.
Okay. So thanks, Lori, and I know Jesus was in the background. Look, you can see their little pictures up there, their little icons. So they've been working hard getting everything ready. Lori even mentioned Alicia likes ICD-10 way too much to make a short answer. See, she knows me so well. Okay, so that's loading. It's almost done. Look at the little line, and we'll get to the next question. So when are you to use modifier XE versus modifier 59? Also, when do you use modifier GC? I've been told it is used only for regular Medicare, not Medicare Advantage. Is that correct? Well, you know what? I am sure Jennifer has an answer to that because she just told us she was in that manual all the time.
Yes. Well, I didn't look up modifier GC yet. I was looking up the other one. Now, the new X modifiers, they've been out for a couple years. They are going to expect use coming up here. Got some changes coming up. So the modifier XE, that one specifically is it's entitled separate encounter. So I know normally we mean 59 is something separate. But remember, this is a separate encounter specifically. So that's a service that's distinct because it occurred during a separate encounter. So that modifier should be used only to describe separate encounters on the same data service. So you may see this if a patient comes into the office and, okay, I'm fine. Later that day, something happens, they go to the hospital and the primary care or the specialist they saw, or whatever the case may be, say they saw a cardiologist earlier today and they said, oh, you're good, and they went back home and they started having chest pain, so they called the cardiologist in. That's a separate encounter on the same day. So we want to make sure that it wasn't just because if they were in the office and the doctor said go to the hospital and then they meet them over there, well, remember, that's only one code you can bill for those 2 services. It'd be the hospital code. But this is 2 totally separate encounters with the same provider or somebody in the same billing under the same tax ID on the same data services, specifically your XE. Remember modifier 59, try not to use that as much. If you can use an anatomical modifier, that would be much better, left or right, TA, T5, FA, any of the other anatomical modifiers that we have would be much better than a 59, but XE is a totally separate encounter. Alicia, did you see what a GC was at all, or Do I need to look at that?
No, because if I go look that up, it will stall everything on my.
I got you. No problem.
Um,
Now,
well, we can.
Medicare Advantage plans may not always. A patient is under Medicare Advantage plan as Medicare Part C, but remember it's run through another carrier. Now, United Healthcare most likely will follow Medicare's guidelines. They're like this, but not every Medicare Advantage plan through a commercial carrier is going to follow Medicare's rules, even though Medicare's paying that bill for them, kind of technically on the backside. That doesn't mean they're going to follow Medicare's rules. They may still follow their own rules. So that would be something to look at their website and see which rules they want to follow.
Medicare Advantage plans would be like UHC, and Blue Cross Blue Shield has one, and all the major insurance providers have an MA plan. So if you want to hear that.
Okay.
Did you find this?
GC is a resident. That goes under your resident under the direction of a teaching physician. So again, Medicare has specific rules and they have a specific section in their guideline for residents and for teaching encounters. And so not all the other carriers are going to follow resident rules as well. So they may not care in a hospital that they saw a resident. You may just bill under the physician. So again, that's something that a separate carrier and Medicare Advantage will fall under a separate carrier's guidelines.
And there was the teaching hospitals. I mean, it was, well, now I think of it not being so long ago but it actually was in the 80s and the 90s when the teaching facilities got hit really hard by fraud and abuse. Yeah, you know. I don't think the 80s and 90s is very long ago, but everybody else seems to. And I noticed another question came up by Jason Washington about XU modifier. But let me tell you real quick. Again, Jennifer is familiar with these, but we actually did, when these were first coming out, a video Joanne did, and I think you're going to be able to find it on our YouTube page. We'll talk about that here in a little bit. You might use that as a launching point. Go back and review that and see if that can highlight some of this stuff for you. And then again, put it in the CCO Club questions. And then Jennifer taps into those and really does a good job of staying on top of our billing questions, which of course Modifier always seems to have an issue with billing, not anything else. So, so yeah, take some time to go do that. Yeah. Don't let her fool you. She secretly loves it. It's not that she doesn't have all the time in the world, right? She has more children than I do. How are the G0444, etc. billed in an annual to be paid? Did you get this in your stuff already? Okay.
And I had the answer and I got off that page to look at something else, and now I got to find it again. Now G0, oh no, that's okay. Now G0444 is the annual depression screening. So that, or not annual, it's the depression screening. So I've got it right here. Oh, I know, that's what I was doing. There's a specific thing on Novitas's site. So, and I know Novitas is not everybody's MAC carrier. It's only in 10 of the states, but they seem to have a whole lot of information. They seem to be on top of the game here. One thing I will mention as well while I'm looking at this is there are some changes coming. So if you are used to looking at the LCDs and the NCDs on your carrier's website, you know, you like to go to them because they tell you what diagnosis you can bill and what CPT code you can bill. That's changing. That information will be coming off of the LCDs and NCDs, but they will link an article specifically for billing and coding in relation to that NCD, LCD. This is an entire CMS policy, so every MAC carrier has 1 year to get rid of that information and redo all their stuff. So it's a gradual process because you're going to see some of them may already be done, because that's if it's a brand new LCD or NCD or something that was up for a change, then they're making that adjustment right now as they go. But they have 1 year to adjust all of this information.
Wow.
So yeah, I was like, oh my gosh, no, you can't do that.
Like, we look at that.
It's the only way you know what to do. Let me see here. Vaccinations reference. I used to have this really nice, yeah, maybe if you want to go to the next one, yeah, see if I'll come up with
Let's
this.
just look at the next one, then we'll go back while she's looking at it. Let's see. If a patient has an exploratory laparotomy with a 90-day global period and they have to reopen it over the next several days and also perform a hernia repair, would the additional service be billed due to the 90-day global period, or should modifier 58 be added in the additional service with the global period? Well, you know, global periods are really, really interesting, but and I'm not an expert in this as well as Jennifer is, again, because this ends up being a billing thing. But I can tell you, yeah, one of the things that you need to remember about a laparotomy is that technically, whenever they open you up to do any procedure, they do a laparotomy. I mean, it's just a given, because you can't treat what you can't see. Okay, so the basic thing they do is open you up and look around, even if they're going to take out your appendix, because they want to make sure everything else is going okay in there, right? They want to make sure that that inflammation that of the appendix, even though they can see it, isn't the only thing that, you know, there might be something else that's inflamed or irritated, like the liver, right? Or if that appendix has been in there and it's rotting and it, you know, has it, you know, leaked or got, you know, purulent stuff anywhere else to affect another organ. So you have to go back and you ask yourself, okay, you know, you got your global period. They do an exploratory laparotomy. Why did they do the exploratory laparotomy and not find something? Okay, now this is just my brain thinking before she tells us the answer. But the other thing, they have to have a reason why
I have
they
the
would go
answer,
in, right? Yeah, I know you will. And the other thing is that okay, because they made it says the next several days they perform a hernia repair. Okay, again, they would have gone and done the hernia repair when they did the exploratory laparotomy, or there has to be another reason. These things are separate. Okay, an exploratory laparotomy is done for a reason, to go see what's done. So I can give you an example of, like, my daughter who has endometriosis, and she has a cyst on her ovary as well, and they said that, you know, they could go in and take care of that cyst and do an exploratory laparotomy to see where else she has the endometriosis, right? Again, there's still a reason why they're going in. They just don't do exploratory laparotomies without a purpose. So again, I don't think an exploratory laparotomy has the same 90-day global period without having something else as a reason why they went in. And if in fact it is, you're doing another procedure. Okay, if they're doing a hernia repair, that, and they went in, that starts another global period. Okay, because it's a different procedure. Does that make sense? I'm not trying to confuse you. I'm just saying that an exploratory laparotomy isn't necessarily always done by itself. If they were going in to see how the extent of the hernia repair was, they backed out because they couldn't do it. They had to wait, stabilize the patient. Then they go back in to do a hernia repair. You're still in the global period, because what was the purpose of the exploratory laparotomy, right? It was to do a hernia repair. Okay, so you really have to have more of the picture to see. Now, again, to go back and say, nope, they just went in to go look around and they got out, and then they went back in a few days later and said, hey, we're going to repair your hernia. you know, or maybe they identified the hernia repair, then backed out and said, you know, we need to get a consent. They could do that. And that, but then you get a new global period when you go in for that hernia repair.
So if they did do some kind of surgery and they're in a 90-day global period and they have to reopen it because of a problem. Now this one, it looks like they did exploratory and now they went back in a couple days later. And in this question, this is something different. They did a hernia repair.
But
not
Jason
the
just said it was a trauma gunshot wound. Okay, well, see, that tells you something
so
else. So if they went in to do exploratory laparotomy for a gunshot wound, okay, and then they went in and said, hey, look, we got a messed up hernia. We could go in and repair that. It's different.
That is something totally different. That's not a return to the ER for the same problem, and it's not staged. 58 is a staged modifier. This is returned. This is 79. This is totally unrelated to the first one.
Right.
And yeah, okay, I wanted to confirm the 90-day global period on exploratory laparotomy too.
And a gunshot wound, I don't think, it would be different. It wouldn't cause a hernia. I mean, yeah, it could cause damage and stuff, but I don't think it would cause a herniation. It would be
because a hernia is the
chair.
Hernia is the, you know, getting stuck in, you know, in the little coil, you know.
But they can't have, you can't have acute, and maybe it's to do with that, but it really, you have to find out, are they relating the herniation to the trauma of the gunshot wound, or did they go in, do a laparotomy to see how bad the extent of the tear and damage was from the bullet, okay, because it goes in there and it jumps around and blows everything apart. So they go in and they say, oh, look, he has a hernia. Let's open him back up and take care of that hernia. See, that's what she's saying. That's two separate things. So yeah. All right. Do we need to go back now? Sometimes we talk about this stuff and we don't know the whole story.
Well, yeah, and that's where sometimes we'll get a question and we'll go, well, it could be this. So if it's that, then here's the answer. But it could be this. So, you know,
don't quote me,
because you just start to look at. Well, and I understand that, you know, when you're dealing with it, it's like, well, of course, that's what I mean. But, you know, because I'm in that situation every day. But when you ask somebody else, they're like, okay, well, do you mean orthopedic? Do you mean cardiology? Do you mean, you know, what's your circumstance or what, you know, what's the circumstance? Oh, yeah. So a lot of times when we get these questions, we send it back going, okay, what insurance are you talking about? Do you mean this or do you mean that? And we need a little bit more clarification sometimes from people.
Or why are you asking? Tell us why you're asking, and that'll help us give you the right answer, because it's just because of, you know, ICD, it's because you didn't get paid or blah, blah, blah. Now
so I am looking at the depression screening. This is an annual screening. You must have 11 months in between the last screening. So it's only once. And there's specific place of services that you're able to do this in as well. 11, so an office, outpatient hospital 22, 49 independent clinic, or 71 a state or local public health clinic. Those are the only places you're able to perform a depression screening on a patient who's Medicare. The screening must be furnished in a primary care setting. So this is your PCPs. This isn't your psychologist. This isn't, this isn't something else, because they're going to do their own thing for depression. They're not going to screen you for depression if you're at a psychologist's office.
Because the PCP is going to screen you and then refer you,
and then send you. And it says with staff-assisted depression care supports in place to ensure your accurate diagnosis and treatment and follow-up. So it's a staff-assisted device. It could be a form or a piece of paper, or it could be some kind of tablet with a program, maybe an assessment guide from a particular society or something like that that's on like a tablet. But that's where it's going to be. It should be, I haven't found anything yet, just in this quick looking, that it would be denied with any of these other annual wellness visits. I don't see them bumping up against each other. So you should be able to bill this as well. But I see this more as, I mean, because this is an annual depression screening, this is one of their preventive services that's offered. So it's not going to be, you know, Miss Jones came in for her 3 chronic conditions that she has and her diabetes follow-up medication. And oh, by the way, let's do an annual depression screening today. I don't see that happening. Hopefully not, because, you know, healthcare now should be driven towards patient care, not, oh, it's been 1 year, how many dollars can we get from this service? Hopefully is not the case. You know, that's where they're changing a lot of services for, you know, the annual, for, you know, driven towards patient-centered care and less paperwork. So
That's really
hopefully
cool,
that answered that question, but yeah.
because that is not a code that's on my wavelength. That's not one I pay attention to. That's pretty cool.
I think I
Okay,
did
so
last year. I think I did
did you do one on there?
I think I did one last year. It's sounding familiar, but yeah, I mean, it's definitely something I don't deal
So
with, of course, in
that's a
my
good
office.
segue. It could be on YouTube, guys. So take
Mhm.
advantage of our YouTube channel and our Facebook page, because Boyd stays on top of this, and we have over 1,200 videos in there, because we've been doing this a long time. So you can go in and do a search, and it's real easy to find it. It's just called medical coding cert in YouTube, and then subscribe. And now they have that little bell so that you can click on it and you'll get a heads up whenever something is new. But put in that code in the search and it might come up and tell you when we did it. Same thing with Facebook. Like and subscribe and you'll know whenever we're doing anything in there. With that, we live stream at least 3 days, minimum 3 days a week, right, Boyd? Minimum on Facebook and YouTube. So that's just free content and info. It doesn't stay up all the time, but that you can get. These are all of our links that you can access us via. Anything I'm missing on that, Boyd, that we need to say? Can't think of anything.
Voice.
We can't hear you, Boyd.
Sorry. The handouts.
Can you hear ya?
There's a handout that's attached in the webinar there. So these ones are linked correctly. The answer sheets are not, they're linked, but they're not accessible to those unless you're in the CCO club. So just FYI on that.
And that's the information about Facebook. Hey, it's just real easy, cco.us. Again, if you like and subscribe, that really helps us, and as well as if you do that on YouTube. You know, there's a lot of free content on both of those. This is just information on how, if you want to place a topic request, you may, you know, after you get out of the webinar tonight, you may think of something, oh, I should have asked. Just go in and put a topic request. You don't even have to pick where you want it to be. Just send it in and we'll find a good place for it. We also are always looking for case studies. That helps us. So like Jason had that great gunshot wound. If you're able to get a redacted encounter like that, it has to be redacted. You could submit that to us and we'll just turn it into a training, a teaching moment for everybody. So, because that was really a good one and we would like to do that. Hey, we go out to local chapters. We have
Alicia would love to do that.
I just posted I was in Seguin. I've gone to Seguin twice, but I was just at their May Mania and I posted on Facebook some of the pictures of everybody there in Seguin. And it's really New Braunfels, but we meet in Seguin, and they're 2 hours and 12 minutes for me. Great, thriving, growing chapter. It was really, really, now that's Texas, by the way. So again, we want to help support the local chapters. Let us know if there's topics that you would like. We do remote presentations all the time, and we're so good at this that the cost to us is minimal. Now, if we come to you, it ends up costing us a little bit, but it's fun. Fun for me, at least. I like to get out of the house once in a while. Don't forget that survey that Boyd gave you. We really, truly appreciate that. And again, you know how to get more information about the Clown Prime. There's a link references, and I think that's it. Oh, and there's our pretty faces. So, is that it, Boyd? Is that everything?
That
there
is
another
all.
slide?
There it is. Yeah. So thank you again,
Oh,
everybody,
he's
for
just got a
joining
new
us.
picture.
Ah, yeah, he put up a new face because my hair's grown out. Yeah,
Skylar's got a
face.
new picture too.
Yeah.
Oh,
Yeah, I got my
Join
hair
us for a
up
day
and
of the week, and you'll see it up and down and out and in and curly and
Yeah.
straight. And
right.
you can probably
That's
see it on
right.
Facebook too. There's some pretty crazy pictures in there, I think.
Oh, that's my personal Facebook. I don't. Yeah.
Oh, okay, good.
Some of you guys are on there though.
you don't
So
want to scare people away in CCO.
Yeah. This is our
Tiffany and
professional-
Tiffany was one of our interns, and now she works for CCO. And she said we should have wacky hair Wednesdays, and because she sent me a text with a picture of her hair all over the place. So
I don't have much to offer.
poor
So,
Boyd, he can't contribute. Yeah.
yeah. I think actually now that I'm looking at this microphone, this is actually the first microphone I started with CCO, and it's gone through a lot. And you know, I lost a headphone, and I was like, well, let's just go with one ear, you know. So there, I'm styling. I think.
I know, but Boyd is a man, so eventually he'll get hair on his ears, or his eyebrows will get bushy as he gets older, and then maybe he can contribute with bushy eyebrow. So
Oh, I thought
with our
that was
wacky hair.
weird. I thought that was just me. That's normal. Okay, great. I feel
No,
better
that's
now. Anyway,
Yay.
thank you everybody for
Bye.
joining us. We're going to say goodnight now, and until next time, happy learning.
Bye.
Bye.